So, main question today, surgery vs camouflage. This is the most important question of today's topic. First thing I want to start with the regular analysis that we usually use, which is the regular S and A, S and B, and A and B angles. Are these angles reliable in taking the decision whether should we treat patients with surgery or camouflage? This is a very good question. Here we see two tracings of cephalograms of two different patients. First patient is a class 2 patient. The A and B angle is 7 degrees. And the other patient also has an A-B angle of 7 degrees. See, this first patient has an angle of 7. He has an obvious class 2 malocclusion with big overjet. The other patient has also an A-B angle of 7 degrees, but he has a normal occlusion. Class 1, regular overjet, good one, overbite. So, what's the difference? So the A and B angle is the same between these in both of these patients, but the occlusion is different. So what should be the treatment plan? How should we treat our patient? Is the A and B, SNA and SNB reliable?
There's a difference in the vertical pattern.
Yeah, and also in the vertical pattern, there's a difference. So let's think about it. Here's a lateral cephalogram of tracing of an average normal occlusion with the A and B 2 degrees. So this is a normal patient with an A and B angle of 2, which is a class 1 skeletal relationship, and he has a dental class 1 relationship. We did a diagram, or the authors of this paper did a diagram of the lateral cephalometric head, and they have diagram of the maxilla, diagram of the mandible, the SN plane. So here, let's take a look at what happens to the A and B angle when the point N moves forward. So the first diagram is an average normal occlusion with an A and B angle, of 2 degrees, which is normal. Class 1 occlusion, skeletal, and class 1 dental. The second photo shows that the nasion moved forward, so the N point moved anteriorly, is located anteriorly, and this has an effect of reducing the A and B angle. Imagine with me, the A and B angle was previously 2 degrees, which is normal. If the A point will move forward, this will mean that the degree, the A and B angle, will become less, which is here -2, which shows a clear class 3 malocclusion. But the patient has normal occlusion, normal anterior-posterior position of the, or a relation of the maxilla to the mandible, or the mandible to the maxilla. Same thing happens when the N point moves posteriorly. So what will happen is that the A and B angle will increase, showing you a class 2 skeletal relationship, but the occlusion is not a class 2 relationship. So the anterior posterior position of the point N will increase or decrease the A and B angle. These patients from 2 degrees to 5 degrees. Another thing that we should consider is also the clockwise or counterclockwise rotation of the maxilla and the mandible. Here is a diagram of an average normal occlusion with an A and B angle of 2 degrees. In diagram B, here we see that we have a counterclockwise rotation of the jaws, which will reduce the A and B angle because we have a counterclockwise rotation. of the jaws, this will bring point A backwards, and this will bring point B forwards. What will happen? This will increase the A and B angle. In the same patient, if we have a counterclockwise rotation, the A and B angle will increase, showing you a class 2 skeletal relationship, but in fact, it is not. The opposite is true also for clockwise rotation of the jaws. This will bring the point A forward, the point B will go backwards, and this will increase the A and B angle. So it was 2 degrees, and now it's 8 degrees because we have a clockwise rotation of the jaws. So the anterior-posterior position of point N and the clockwise or counterclockwise rotation of the jaws. This will have an effect on our angle A and B. Another factor that we should consider is the SN plane tipping. So if we have a tipped anterior cranial base, this will affect the SNA and the SNB angle. So here we have a tipped SN plane. This will reduce the SNA and the SNB, which will show you a retroposition of the maxilla and the retroposition of the mandible. But this may not be correct because we have the tipping of the SN plane. So this tipping will affect the SNA SNB angle. And this will give you a false reading of the A and B. Tipping, like rotation. Understand? Like a rotation. So point N is higher than point S here. So it's like tipping counterclockwise, let's say. So we need another cephalometric parameter that will help us identify what should we do with this patient, how to properly diagnose it, and to avoid these irregularities with the A and B angle. We have the width appraisal. What does this mean? So from points A and B, we draw perpendicular lines to the occlusal plane. I think it's clear for everyone. So we have the occlusal plane and the points A and B. From points A and B, we draw vertical lines to the occlusal plane. So the point of intersection between the B point and the occlusal plane, we will call it BO. The line coming from A to the occlusal plane, we will call it AO. So usually, point B is in a backward position in relation to point A. This means that the point BO will be regularly behind point AO. So the distance between points BO and AO will be the measurement of the width appraisal. And it's going to be positive. So as long as BO is behind point AO, the measurement is positive. So this width appraisal of jaw disharmony is a measure of extent which jaws are related to each other anterior posteriorly. So here we do not use the cranial base. We relate the anterior posterior position of the jaws to each other. Research says that the average jaw relationship according to width reading is 1 millimeter in males, 0 in females. So in males, point BO is located 1 millimeter behind point AO. So here we will see some examples of applying the width appraisal. A and B angles are the same, 7 degrees. The width appraisal in patient A is 10 millimeters, which is an obvious class 2 skeletal. But in patient B, he has a 7A and B angle, but the width appraisal is 0. which is easier to treat? So the patient with the width appraisal closer to the normal is easier to treat than the patient with the same A and B angle, but a higher width appraisal value. So here is a class 3 example. Also two tracings. First tracing is a class 3 malocclusion, and the A and B angle is minus 1.5. Well, we all understand that the normal A and B angle is about 2 degrees, right? Maximum it's going to be maybe 0, and then you will have a tendency to class 3 malocclusion, right? So this patient has an A and B of minus 1.5, mild class 3 jaw disharmony. Width appraisal is minus 1.5. Minus 1.5 millimeters means that the BO point is located anterior to the AO point by 1.5 millimeters. Clear? In patient 2, he has minus 1, also class 3, but the A and B shows less severity than the first patient. But when we take a look at the occlusion, it's a lot more severe than the first one. Let's take a look at the width appraisal of this patient. He has minus 12 millimeters of width reading, showing a big discrepancy. So the BO point is anterior to the AO by 12 millimeters. Here is another 2 cases with vertical changes. See how the vertical changes will also affect the treatment plan. Both patients have A and B of 9 degrees, both of them. This patient has a width appraisal of obvious 8 millimeters, but this one has a width appraisal of 1.5 to 2 millimeters, showing you completely different treatment plans. So our first question was surgery or camouflage. How should we use this width appraisal in answering our question, in making the decision? Here is a study studying the treatment decision in adults with class 3 malocclusion, surgery vs orthodontics. Here we had 65 patients divided into 2 groups. Both groups are class 3 skeletal patients. First group was treated by camouflage. The second group was treated by surgery. First group consists of 36 patients. The second group is about 29 patients. So the camouflage treatment involved flaring of the upper incisors, so proclination of the upper incisors, and retraction of the lower incisors, regular camouflage treatment. The surgical treatment involved setback of the mandible, or maxillary advancement, or bimaxillary surgery. So they had the results showed that we have 2 important parameters. First one was the obvious width appraisal. The second one is the hold-away angle. We're not going to dive too deep into the hold-away angle to make it a little bit simpler. So these parameters were able to differentiate between the patients suitable for orthodontic treatment with camouflage or with surgical treatment. So these parameters were accurate in about 81.5%. So 81.5% of these patients were properly classified according to these parameters. So the conclusion is, if you have width appraisal which is more than minus 5.8, which means closer to the 0, this means that this patient can be successfully treated with camouflage. If you have width appraisal which is less than minus 5.8, which is away from 0, like -6, -7, -8, etc. This means that this patient should be treated surgically. Clear? Any questions? Do we have any questions on Facebook? For now, no questions.
Yeah, and I will bring a little bit more clinical
Yeah, more clinical.
slides. Okay. So let's look at some clinical cases, okay? And I'm expecting some discussion on this. So this is a young gentleman. He was 17 years of age when he first came to our clinic with a chief complaint of crooked teeth. He didn't like how his smile looked. Let's look at his face first. This is his face. Well, we can tell that he had a little bit prominent lower lip, not a prominent chin. Let's look at his intraoral pictures. So intraorally, we can clearly see that he has some midline shift. Is it a dental midline shift or is it a skeletal midline shift? Well, of course, we can look at the facial photos, but it's much better to look at it on CBCT. And when we look at CBCT, we can clearly see that there is no significant skeletal asymmetry. So his midline shift is mainly dental in nature. This is due to the blocked upper right lateral incisor. This is his panoramic X-ray, nothing remarkable here. And this is his cephalometric image. These are the numbers. Well, there are several important issues. His lower incisors are slightly proclined. His upper incisors are very much proclined. And his A and B angle is -1 degree. What about his width appraisal? Any guesses? So let's look at his width appraisal. His width appraisal is exactly -5.8 millimeters. And as you remember from Dennis' part, this is exactly the borderline number between acceptable camouflage and surgery. I'm not making this up. This is really what Dolphin program showed me recently when I was making my tracing, -5.8 degrees. And I was surprised that, you know, I exactly on the borderline here between surgical and non-surgical solution. So from this point, we can have some discussion. What do you think? How we should treat him? Any suggestions?
17 years old.
He's 17, yes.
What do you think?
Any treatment plans? Maybe Damon brackets, some expansion, then a round of Invisalign.
Waiting for it and make a surgery.
Yeah, this is actually the perfect solution for him. This is exactly the perfect solution for him. Why? First of all, you are quite correct that we have to wait, well, I would say at least for 1 year, just to take another cephalometric record and compare these two, the current cephalometric record and the one in a year. We have to superimpose and check if there is some residual growth going. This is very important in class 3 cases. And yeah, I'm quite, I agree with you that this case should be better treated with surgery because according to his numbers, according to his width appraisal, he is very much a surgical case. Yes, he's a borderline according to the numbers presented in the paper, but again, I will be much more comfortable treating him surgically because I will be, you know, certain that this solution will be stable, we'll have a quality occlusion, a good bite, etc., etc. But there is one issue about this young gentleman. when he came for a consultation, he told me that he is about to relocate to another country for an education very soon, in about 10 months or so. And of course, this is a psychological social issue. He will be entering a new social group of his peers. Of course, he wanted a better smile when he will be, starting his education in another country. And he said, well, I'm not considering the surgery at the moment. And definitely I will not be doing surgery at another country. He said, by now, I just want some improvements of my smile. And later, maybe in 5 years, in 10 years, I will reevaluate, the situation, and maybe I consider surgery later down the road. We had a long discussion with him, with his parents. I told them that, yes, probably I can do a camouflage, but this won't be the most stable result, first. And second, I told them that later, there is a chance that he will require surgery anyway, because there might be some residual growth, etc., etc. So giving all the, risk factors, I laid down all the risk factors before them and said, I can promise you that the result will be acceptable for about 5 or so years after the treatment. What will be happening next, I do not know. Maybe you will need to have surgery later on. And they said, okay, we're quite comfortable with this treatment plan. We want a camouflage treatment now, and later potentially we'll go for surgery. So before we delve into the treatment itself, I want to go back to very basics. What is the classic extraction pattern for class 3 camouflage cases when there is crowding? This is a question for you.
Extracts second premolar maxilla and the first premolar.
Exactly. The classic pattern of extraction in class 3 camouflage cases is extraction of the upper second premolars and lower first premolars. What we are getting by this, classically, there are two most prominent features of a camouflage class 3 cases. The first feature is increased upper incisor inclination, and the second feature is decreased lower incisor inclination. And when we have such features, the important thing which we have to be careful about is labial cortical plate. We have to be sure that there is enough labial cortical plate, because our lower incisors are becoming very much upright when we go for camouflage and class 3 cases. So let's look at his lower incisors. The feature which I liked about this case, and which actually supported the decision of camouflage, is that his lower incisors was initially slightly proclined, and this helped me to protect his basal bone, because I was retracting. Of course, I was retracting his lower incisors back and retroclining them. But if you initially have some proclination of lower incisors, you have some room to do it. You have some room to retrocline them without damaging your labial cortical plate. Of course, if we deal with retroclined lower incisors initially, I'm not sure that camouflage treatment is a possibility. So let's look at the treatment progress. So I started with the extraction of upper second, lower first premolars. I started space closure. As you can see, there are lace backs on the upper arch. I started a space closure on stainless steel round wire on the lower arch. This is a tricky thing to do. You have to be very careful when you're going to to close space on a round stainless steel. Why you have to be very careful? Because you are about to lose your torque on lower incisors, and you have to make sure that you are not losing too much of a torque. Okay, so here you can see that I already started opening the space for his upper right lateral, and at this point, he was transferred to another country for continuation of treatment. He was transferred to Spain, to the orthodontist mentioned here, and she continued with my initial treatment plan, and she was very careful about documentation, very meticulous. She took photos each and every step of the treatment, and I absolutely like this approach. I'm not that meticulous about my documentation, but probably I should be. This is the way to document all of your cases, to take pictures each and every appointment, because this way you will know where are your mistakes, and this way you will be able to correct your mistakes later down the road. So now you can see that she used class 3 elastics. At some point she used asymmetrical class 3 elastics from one side, class 2 from the other, to correct his midlines, and some more asymmetric elastics. At some point she was using closing loops on the lower arch to close the extraction spaces, and these are the finishing appointments and his final result. So this is his final occlusion. What you can tell from these pictures, definitely his lower incisors are very much uprighted. And I'm not very comfortable about the periodontal status here in the labial segment. There is a high risk of recession, development of recession down the road. So if you ask me if I consider this a good outcome or not, I would say, well, this is definitely an extreme compensation. But giving, social considerations, giving circumstances which I outlined in the beginning, I think that this is an acceptable treatment plan in his case. He was very happy. He was very happy about his new smile. This is him. So the treatment was about 2 years, a little bit less than 2 years. And these are his pictures, lateral photographs of the face before and after the treatment. From the cephalometric records, you can tell that his lower incisors became very much uprighted. And these are the numbers. You can see that the main change was the change in IMPA, in the angle of the lower incisors. We uprighted the lower incisors about, 14 degrees. Yeah, and this is a superimposition. And you can clearly see that the main change is in the lower incisors. Again, it would be probably much better for him to have surgery in order to have a better situation over here in the labial lower segment. But given the pressures of the day, given the pressures of the circumstances he was in, I think this is an acceptable but extreme camouflage treatment. Well, I'm not really like the position of the lower left premolar. It is slightly tipped forward. I wish it would have been in a more parallel, in a more uprighted position. Probably if the space closure will take more time, we'll have it in a nicer position. But all of our cases have some inaccuracies. So what I think yes, that there is a risk of potential recession in the labial region. Could it be corrected with periodontal work? Yeah, probably it could be corrected. What will happen to this occlusion in 5 years? I do not know, but I clearly know what has happened to this occlusion in 1 year. This is his occlusion 1 year in retention. Not many changes, right? Before, after. Before, after. So this is the case number 1, extreme dental compensation. And as you remember, he was minus 5.8 millimeters width, exactly the borderline case, according to the paper which Danny quoted before. Any questions about this case? So, no question.
Ideal surgical plan.
My ideal surgical plan for this case, that's a good question. My ideal surgical plan for this case would be extraction of the upper 2 premolars and no extraction on the lower jaw.
Maybe upper 4s?
Upper 4s or upper 5s. I think both solutions are absolutely possible, absolutely valid options. Again, maybe it will take more time and more work if you extract the upper second premolars. Maybe it will be a little bit faster if you extract upper first premolars, but looking at the anatomy of his upper premolars, I probably prefer to preserve his first premolars because they're a little bit larger, nicer anatomy. His second upper premolars are smaller, so probably I would better leave him with first premolars. Do you agree?
Yeah, sure.
Right. So now we are going to look at another case. I'm not sure if Mauro is following us. He's muted. Okay. All right. So now we are going to another case. Let me share it on Facebook as well. All right. So this is the case number 2. A lady of 42 years of age. Her chief complaint sounded like, I want to fix my bite. And this was her bite. A crossbite, anterior crossbites, well, posterior crossbite as well. She was class 3 molar relationship on the right-hand side. I'm not sure about molar relationship on the left-hand side. There are not many molars there, but definitely some midline shift. And according to CBCT, this midline shift had a skeletal nature, right? There is a obvious skeletal asymmetry of the mandible. It's not a functional shift. It's a real asymmetry. This is her cephalometric image. And as you can see, her lower incisors are retroclined, just as her upper incisors. Her upper incisors are also retroclined. Her A and B angle is minus 2 degrees, not a very big difference from the previous case. Previous case had A and B angle of minus 1 degree. So more or less the same A and B angle. But what about her width? Any guesses? What's her width appraisal? The last case had a width appraisal of minus 5.8 degrees. What do you think? What is a width appraisal in this case? Just looking at this picture, approximately. Is it more than 5, less than 5, closer to 0, away from 0? You mean less than minus 5?
Only minus 5.8.
So just roughly guessing. We are guessing here. You mean minus 7, minus 8?
Yeah.
To this direction.
Need to do surgery.
Okay. So tell me, Danny.
Maybe minus 3, I think.
Minus 3. So closer to the 0.
Yeah.
All right, so her width appraisal was minus 12 millimeters. Minus 12 millimeters. And this, for me, was an obvious class-free case. This is her panoramic X-ray. Well, she had a lot of wisdom teeth in place, so we had to remove them, of course, and we started to prepare her for a surgical option. And now looking at this picture, can you tell me what is unusual about bracket positioning on these pictures? Anything unusual in bracket positioning here? What do we do differently usually in class-free pre-surgical orthodontics? Right, so I usually, well, actually, in all of the cases, I use MBT prescription. Do you use MBT prescription? Everyone uses MBT prescription? Just a classic MBT prescription. This is a classic MBT prescription, and the torque on the lower incisors in it, on all low incisors, is minus 6 degrees. So it is very common that class-free skeletal cases have very much uprighted lower incisors. So preparing for the surgery, doing our decompensation, we are very often have to slightly increase the torque of the lower incisors. So when we flip the bracket, when we invert the bracket, just put it upside down, we actually change the torque from minus 6 to plus 6 degrees. And as a result, our lower incisors are getting slightly tipped, proclined forward. This is what we usually want to achieve in class-free pre-surgical treatment. If you look closer here, the lower incisors, her lower incisor brackets are placed upside down. And here I had a battle for a while with this tipped forward second molar on the lower jaw, and I was using various springs and power chain, but then I just placed a mini implant, a small mini implant behind my tooth, and I attached a button on the occlusal surface of the second molar, and in a matter of months, I uprighted this molar simply with a screw. So now I have enough space for an implant.
But it did not extrude. Or what was the factor of force on the ground level?
I will show you the final panoramic X-ray to answer this question. So, this is pre-surgical setup. We have hooks on our working wires, 90, 25 wires and 22 slot, and we have lacing on the upper and lower jaw. This is how the patient looked pre-surgically, and this is the final pictures. The surgery was done by Dr. Andrei Sinyuk, who is one of the most prominent orthodontic surgeons in Russia, and I'm very honored to work with him under the same roof. It's a huge privilege, and I learn a lot from him every day. Okay, and these are the before and after lateral facial photographs. This is her occlusion, final occlusion, and on this slide you can appreciate how symmetrical she looks after the surgery. Okay, she's absolutely symmetrical now. This is before and after cephalometric images, and these are the tracings, initial and final. So we can see that lower incisors were slightly tipped forward. We went from 85 degrees IMPA to 90 degrees IMPA, and similar changes with the inclination of the upper incisors as well. So her Witz appraisal changed from minus 12 millimeters to minus 2 millimeters, which is much closer to the norm. These are the changes, the surgical changes mainly. You can appreciate on the superimposition that her maxilla was downgrafted during the surgery, and her mandible was slightly clockwise rotated. This is a common rotation in surgical class 3 cases. And this is initial and final, always final, before the debond, panoramic X-rays. And yeah, Deli, to answer your question, I do not think that much of extrusion happened to this lateral,
So the mini implant was
to the second molar. Sorry?
was the mini implant was retromolar area. So it's
Yes, it was in the retromolar area, just in the place of removed wisdom tooth. And yeah, we got some uprighting of this. If no, of course, no distalization, just a pure uprighting. Yeah. So, okay, so this was the second case. Any questions so far? Some questions.
The direction.
Some questions from Facebook. Okay, flip low inside. Tell me.
Who decides the direction of the movement of the maxilla and the mandible? Is it up to the surgeon or the orthodontist?
Of course, surgeon. It is surgeon who decided. What we discussed with surgeon initially, before placing the brackets on the teeth, we are discussing to what position our teeth should be placed before surgery. Yeah, we are discussing it together. But as Maura said before, if you're working with a surgeon for a number of years, you don't have to discuss anything. I mean, you know each other so well. I pretty much know what my surgeon wants from me. He knows what I will be doing. If there is a crowding, we extract. If there is a retroclination, we procline a little bit, vice versa. The main thing is to get rid of natural compensation, natural dental compensation. You have to decompensate the case to normal dental inclinations. That's it. Any questions from Facebook? We see some activity on Facebook. Any questions? Please ask. Okay. We are moving to the third case for today. And this is a case I debonded just yesterday. So, all right. All right. So, this is a young lady of 21 years of age. She came for initial consult with a chief complaint of crooked teeth. This is how her face looked, and if we look closer at her face, we can see that there is some lip incompetence. She couldn't close her lips completely. There is no complete sealing of the lips, and there is some mandibular deviation to the right. Can you see? The chin is a little bit to the right. When we look at her CBCT, we can see that there is some degree of skeletal asymmetry. The mandible is slightly deviated to the right, and actually her upper jaw is also slightly deviated to one side. This is a very important, issue. You always have to look at frontal radiographs. Would it be 2D or 3D radiographs in order to assess asymmetry you have to look at the radiographs from anteriorly. You cannot, be enough only with your SAFs. Right, so this is how she looked dentally. You can see that both of her molars, left and right molars, are in class 3 relationship, and there is some midline shift due to mandibular asymmetry. Panoramic X-ray, not many remarkable things here. And this is her cephalometric image. You can clearly see that she is a high angle case. She's a vertical case. Her vertical dimensions are increased. Some open bites. And these are the numbers. Increased vertical dimensions. FMAA angle 29. It should be around 25. What else? Very much proclined upper incisors, 122 degrees, right? 20 degrees of excessive proclination, and slightly retroclined lower incisors. Her A&B is actually 0, but there is some class 3 tendency. Guess her width. Let's do guessing. And our Facebook attendees, please guess as well. What is her width? What do you think? Anyone?
10, 10,
Minus 10.
minus, yeah.
So is it greater than minus 5.8 or it is closer to the 0? Surgical, non-surgical?
Surgical.
Surgical. Okay. So surgical. All right. So I measured her width and it was just minus 3 millimeters. So basically, she is in the category of nice camouflage possibilities, right? But there is definitely an issue. And the issue is her asymmetry. She is asymmetrical. And this is a skeletal asymmetry. So when she first came to our clinic, she had a consultation with the surgeon. She had a consultation with me after the surgeon. And we told her and her parents that ideally she should be treated with surgery. And the parents and they were not very happy with the solution. And they say, well, we don't like a surgical option. And then the patient left. She left, but her younger sister came for treatment. Her younger sister didn't have asymmetry. And I started treatment of her younger sister. And I finished her younger sister to a nice result. And then her elder sister came over and I started treatment of her elder sister. And then her father came over and I started treatment of her father. And then her mother came over and I started treatment of her mother. And then whole family was in treatment. And she came again for a second consultation. And she said, well, you're treating all my family. And maybe, just maybe, there is some non-surgical solution for me as well. And she said, I'm accepting my asymmetry. I mean, I accept this. I have no concerns about skeletal asymmetry. But maybe you can treat just my dentition. And I said, well, if you're comfortable with your symmetry, we may treat your dentition, of course, with some extraction treatment. But I'll tell you that asymmetry will not go away because, well, it is on a skeletal level. So we started treatment with a classic extraction pattern for class 3, right? The same pattern as in the first case. Upper second premolars, lower first premolars. And as you can see, she initially had a crossbite on the right-hand side, posterior crossbite unilaterally. And I placed initially a bite turbo with a slight inclined plane. Then I was using for a while crisscross elastics to correct this crossbite. And then I always closed all the spaces. And I was using class 3 elastics, but not usual class 3 elastics from upper molars to lower canines, but class 3 elastics which are moved slightly mesially. Why so? I want to go to some, basic biomechanics about elastics. We know that elastics are causing some effects on our occlusal plane inclination, right? So when we are giving class 3 elastics to the patient, what we are about to expect, we know that the center of resistance of our upper occlusal plane is just in the middle of dentition. Same goes about our lower occlusal plane. And when we are giving our class 3 elastics, we are actually rotating our occlusal planes around our center of resistance. So our upper molars are actually end up extruding. But do we want to extrude our upper molars in this case? You can see that initially she already had some posterior gummy smile. So we do not want this movement in her case. On the opposite, we actually want to rotate her upper occlusal plane slightly clockwise, right? So we move our class 3 elastics a little bit more mesially from canine to the hooks on the lower arch, and we are getting this rotation. And look, before we didn't see almost no gum above her upper front teeth, and after some wear of elastics, you can see some dental papilla above the upper front teeth. These are my finishing elastics, and now I'm finishing her with class 2 elastics. Again, I'm moving my elastics even more mesially. I'm using Kobayashi hooks, ligatures over here on my laterals. And you can see that there are 2 elastic bands on the right-hand side and 1 elastic band on the left-hand side. Why so? I'm trying to address her midline shift. And these are her final records. I debonded her just yesterday. So her gingiva is a little bit swollen. There is some inflammation over here. It will heal in a few months. I'm using an extended lower fixed retainer from premolar to premolar to keep the spaces, the extraction spaces closed. And I think this is an absolutely nice camouflage dental result. What do you think? This is how she looked facially. Yes, there is some mandibular asymmetry, but we agreed that we will accept it. And this is the panoramic image which I took just yesterday. And you can appreciate that all her roots are parallel. This is an important issue for stability. Before and after cephalometric image. And you can appreciate some changes in her lower third of the face. You can see some strain in mentalis muscle initially. Now it looks much better. Why so? Because there was a slight, very slight, but it was an important thing in her case. There was a very slight counterclockwise rotation of her mandible due to extractions and due to the movement of molars, her molars mesially, right? You can see that her FMA angle was 29 degrees, and now it is about 2 degrees less. So we slightly rotated counterclockwise her mandible, and also her point B, according to my measurements, also moved about 1 degree forward. Again, this is very slight changes, but I can see them from the profile look. Do you agree? Okay. So these are the cephalometric measurements. Again, you can see that some counterclockwise rotation was happening. Why it was happening? Because you can clearly see that molars, they moved mesally. Okay. This is her images from this angle, 3/4, and her CBCT from anterior look. And again, some skeletal asymmetry is still there. We didn't do anything about skeletal asymmetry, but I think this is a nice, acceptable camouflage treatment. Again, she was -3 millimeters width. She had -3 millimeters width appraisal. So we just looked at 3 cases. The first case had a width appraisal of -5.8 millimeters. It was an extreme dental camouflage. The second case had width appraisal of -12 millimeters. It had a nice surgical outcome. And also we had a case with width appraisal -3 millimeters. And this case had a nice dental camouflage. So to conclude, I think that the paper which Danny quoted before is a very good paper as a reference. Of course, sometimes you can just look at the patient and if skeletal discrepancy is so severe, you know that this is a surgical case just by looking at the case. But there are some borderline cases. There are cases where you're not quite sure about, treatment plan. So this number, this -5.8 millimeters, is a good reference point. Now I want to ask and answer this question. But what about molar distalization? All these cases were class 3, right? Maybe we could have distalized lower molars, all the lower dentition backwards, and correct our class 3 this way. So could those class 3 cases have been treated with the mandibular molar distalization? Before I look to scientific evidence, I want just briefly outline that there are 2 options to push your molars back. The first option is called uprighting. It is when your root apexes are staying put at the same place and you're just uprighting your crown. And the second way you push your molars back is called pure distalization. Is then you have a bodily movement of both your roots and your crown. So we are more interested in pure distalization because neither of the cases I presented had tipped forward molars. All the molars in the cases I presented were more or less uprighted. So we are interested how much we can distalize the roots, okay? So I want to look at this paper first. This is a very recent paper, 2022, published last year in the American Journal of Orthodontics. So, subjects and methods. Subjects and methods. In this study, the authors collected a sample of 40 patients with class 3, and 20 patients were treated with molar distalization on the lower jaw with mini screws. Mini screws are very popular now. They're highly advertised, marketed. Everyone uses mini screws nowadays. It looks so. And 20 other patients were treated with distalization with the help of mini plates. You know what mini plates are. They provide even more stable anchorage. So what were the results? The mean amount of distalization at the root level of the mandibular molars was just 0.6 millimeters, half a millimeter. Is it enough? I don't know. I think this is just ludicrous. That's laughable. And the plates showed us the distalization of 2 millimeters. Is it enough? Well, maybe in some cases, but is it stable? Would it be stable? To answer this question, we have another study, and it was published a while ago in the American Journal of Orthodontics. And in this paper, the authors also looked at the distalization on the lower jaw with plates, and they found pretty much the same number. The molars on the lower jaw would be distalized 1.8 millimeters, more or less the same number. In the previous paper, they distalized 2 millimeters. But the beauty of this paper was that in this paper, they actually looked at the same patients 1 year after the treatment, and they found that average amount of annual relapse was 0.3 millimeters. So if you do your calculations, do your math, you can understand that in 6 years, there will be no effect of molar distalization with plates. And in 2 years, there will be no effects of molar distalization with screws. So that's it. And I want to finish my today's talk with a parable about two ancient Greek painters, Zeuxis and Parrhasius. And as story goes, once these two painters contested who is the greatest realist painter of the time. And Zeuxis painted grapes so lifelike that when he turned off the covering from the canvas, birds flew down to peck at them. But then it came to Parrhasius, the second painter. He actually asked his opponent to open the canvas for him. And Zeuxis tried to push aside the cloth covering Parrhasius' painting, but the fabric turned out to be the painting itself. So I think this has a lot to do with contemporary orthodontic landscape, especially when we have, all this development of social medias, et cetera, where we constantly see all these cherry-picked cases, nicely photographed, but very often these cases are presented without any cephalometrics, without any X-rays at all. And these are most of the time just partial records. So you have to understand that publishing something on Instagram is not the same as publishing something in a peer-reviewed journal. All right. And when you see the next time someone trying to distalize molars of a severe class 3 case on the lower jaw, you have to understand that this person probably is not familiar with scientific evidence, and he or she is probably delusional about his or her treatment. And again, I wanted to remind you of this paper which Danny quoted in the very beginning. This is a paper published last year in the English Orthodontist. And the authors said that less than 2% of the claims on Instagram are objectively true. So 98% of what you see on Instagram is nothing but a deception. So do not be misguided by what you see on social media. And my last slide, very simple message for all of you today: watch less, read more. So thank you for your attention. And we are concluding our lecture part for today. Any questions? Any questions from Facebook? Guys, please ask questions. Any questions about the cases, maybe?
So the most important factor to decide whether we do camouflage or surgery width.
Yeah, width. Why? Because it shows you the real discrepancy between upper and lower jaw, anterior posteriorly, right? Yeah.
So the only factor.
It is one of the main factors. Again, as I said initially, another important, very important factor is the inclination of your lower incisors, right? If they are already retroclined, you cannot retrocline them more. If they are proclined, yeah, you can extract some premolars and try to retrocline the lower incisors in order to correct the negative overjet. This is another important factor. What are the other factors? Periodontal biotype. If you see recessions, if you have retroclined low incisors and there are already recessions going on, you cannot camouflage it more because there will be even more recessions. So yeah, I would say that anterior posterior positions of the jaws, inclinations of the teeth, periodontal bite type. These are the main factors. Plus, of course, you have to take into consideration what the patient wants. As in my first case, he was a surgical case. Yeah, by any means, he was a surgical case. But there was some minor room of possibilities to treat him in a non-surgical manner. And given these circumstances, he said, I'm not considering surgery. I'm leaving for another country for education. There was some anterior posterior discrepancy, but it was not that severe. So I could manage him without surgery, given the circumstances. Of course, if in his case, this would have been, let's say, minus 12 or even more, then I would say, no way. I would not damage you. I would not harm you. Maura?
Hello?
Yeah. Hi, Maura. Hello again. Have you been following, no?
Not too much, unfortunately.
Okay. So, how's the clinical routine? How is it going?
Unfortunately, too good.
How many patients you've seen so far?
Forget it. A few consults. So that was the reason why I couldn't follow too much, because with consultation, you have to be and talk there. You have to be there and talk. I mean, that's it. But I think that you have finished, right?
I've just finished.
Good. So I have to say goodbye to everybody, I think, at this point.
Yeah, thank you, Maura, so much for your part. It was a very interesting lecture and very educational cases. Thank you.
Thank you.
Thank you very much.
So we are concluding our online part.
Goodbye.
Bye-bye.